Hi, everyone. How are you? My name is Vale. It's really nice to see a great crowd today for a new virtual morning report. I'm really excited to be back and then the discussion seat after a while with Rabih here, an amazing team doing scribing and teaching points. So before we start with any discussion, we would like if any of you has a case to share with us. It can be really of any type of medicine. I prefer neuro and ID, but you can surprise me for sure. So yeah, just a little bit about myself for the people that may not know me. My name is Vale. I'm a final year medical student in Peru. That sounds really nerve-wracking. And yeah, I love running, which is kind of my main hobby outside of medicine. I'm really excited to discuss today. So how are you, Rabih?
I'm doing very well. It's been a long time, Vale. We haven't shared the stage in too long. For those of you who are part of a newer and newer wave of IMGs joining this crowd, I think you ought to know that Vale was essentially one of the very first folks who had joined the CP solvers from outside the United States. So whenever I get to see you, Vale, it's always a treat. It really, really is. So we'll lean on the crowd to see if anybody has a case. So if you're on the fence or have a case, please jump in. We only have 30 minutes to nerd out today, so we'll love to nerd out with you. I'll pause and see if a friend has a gift to share with us today. Oh, actually, in the meantime, we should probably introduce you to our nearest and dearest VMR team member. Gurbani, do you want to say hi?
Hi, everyone. My name is Rabani. I'm a medical student at UCSF. Excited to test my words per minute today.
You will fly. Absolutely no doubt about that. No doubt about that at all. All right, y'all, don't be shy. Who has a case? From pneumonia to poem syndrome to... Yeah, I don't know if you noticed, Vale, I said ID things and neuro things for you. Poems and pneumonia, just for you. Shema, where are you? It looks so nice.
It's in front of the library. I was waiting. Yeah.
Oh, it's beautiful. All that is the library? Oh my gosh.
Yes.
Oh, that's incredible. That's really, really cool. Shema, instead of a case, maybe you can just give us a tour of the library, because I don't know if anybody has a case today. I see Hans is pensive. Hans, are you pensing about a case? The journey to the mute button. What a great one. Oh, no case. Oh, bummer.
I don't have a neuro case. That's
no worries at all. How are you?
He doesn't have neuro.
Could be anyone. Well, I think people are just intimidated by your brilliance. I think they're really scared.
I doubt that, but yeah, Hans, I think I understood you meant like you don't have a neuro case. It doesn't have to be neuro. I was just joking. I may be a little more nervous if it's not neuro, but it's okay. Really, any type of case will be amazing. Oh, I see Austin is coming to the rescue once again.
As per usual. There's a very high chance that I get to meet Austin next month, and I'm so excited. Austin, say hi, please.
Hey guys, how's it going?
Good.
Let's see if I can unmute my camera. Let's see. Hey.
Hello.
So, yes, I gotta shave this beard here soon, so I was scared to reveal it to everyone. But, it's good to see everyone, and yeah, I've been writing up this case. So it's not well divided up into aliquots or anything, but I'll do my best to try to organize it.
You're the best. You're the best. Thank you so much. We really appreciate it.
Sure
All
thing.
right, well, I'm ready whenever you are, buddy.
All right, so I guess I'll just wait for someone to pull up the board here. Okay, sweet. So this is a story of a 20-year-old woman who's coming in with what she described as head pain.
Okay. Okay. Well, head pain, that's a very unusual way to frame it. I think, I mean, the way you're saying it, I don't want to assume it's a headache. And I think that's a great reminder, because I think when it comes to head pain, we tend to jump into the more like neurological diagnosis, thinking about the brain and the vasculature, like the vessels. But of course, it can be something way more common and simple, like trauma, for example, or muscle pain, like tension headaches. So just to frame it, this is a fairly young female presenting with head pain. Now, I think I'm just going to jump into the headache category because I feel more comfortable with that. I will differentiate it between primary and secondary causes of headaches. And in the primary causes, you can have tension headaches, migraines, and some other types of more diverse headaches like neuralgias and some of the spectrum of trigeminal headaches. And when it comes to, I mean, the most common ones, tension and migraines, of course. So I would like to know the pattern of the headache, of the head pain, as you framed it, if it's all the head, if it's just one part of the head. And also, as everything in neuro, the time course is key. So to know the pattern of the temporary course, if it's something recurrent, episodic, is something persistent, something new, if this patient has migraines and it's just a type of change in the type of migraines that she's had, which could also be a red flag. And talking about red flags, I think also a reminder of things to keep in mind, that if I see this patient on the ED, will make me think that I need to do like a deeper workup. As a patient having fevers or any other systemic symptoms that could point to something like a meningitis. Or if this patient has risk factors, for example, is using medication that makes her like in a hypercoagulable state, or if this patient has the worst headache of her life, a thunderclap headache, if this patient is pregnant, if she's having any neurological focalizing symptoms such as a seizure or blurry vision, that could point us to increased intracranial pressure. I think, I mean, I'm covering the pneumonic here, so which I think makes a good overlap. But yeah, I think it's my first train of thought. What are you thinking, Rabih?
Yeah, Vali, I think you absolutely laid the framework for what we're going to map onto, and the framework that you're saying is operationalizing the deeper concept, and the deeper concept is: are we going to come to a diagnosis by finding things? And we find something on imaging, find something on exam. And though if we find something, we may find something in the brain, like a brain tumor, or we may find something around the brain, like glaucoma. But it's not uncommon with headaches, especially headaches not presented on VMR, to not find anything. And the exam and the evaluation to be completely normal, in which case we go back and we study the pattern of the headache to come up with diagnoses of exclusion, like migraine, like tension headache, like trigeminal neuralgia. So what you just did operationalizes that concept, and that's what we need now. But remember, all that operationalizing is really answering the question: are we going to find something specific? That something specific could be inside the brain, right next to the brain, and or also we might not find anything specific, and those are the primary headache syndromes. And I love the very first thing you said, the fact that this patient is using head pain has you wondering whether you might find something specific, but that something specific may be actually in the head, not in the brain. And I think you were alluding to that, and I completely agree with that initial instinct, but I'm glad that you painted the broader picture that we should adhere to. Alrighty, Austin, tell us more.
All right, yeah, awesome discussion so far. So, basically she described these as sort of paroxysms of a popping sensation in the back of her right side of her head. And she had described it as if like her brain was getting caught like on a ledge, like it was getting stuck and sort of sliding down. The symptoms had begun 9 months prior to this and had just become progressively more frequent, and were accompanied now by sort of a persistent feeling of like tension in the back of her head as well. Just to let you catch up here.
Sorry, could you repeat the time that you mentioned?
She'd been having symptoms for 9 months and had progressively worsening, this is what you're saying. And there was no preceding trauma. She didn't notice that there were any positions or any movements that would sort of exacerbate her symptoms, but she did notice that on days in which she was sort of struggling with her mental health more, her symptoms would become more prominent. And she had no numbness, tingling, weakness, like any sort of neurologic symptoms or red flags as far as like bowel or bladder incontinence, anything like that. Do you want to talk there, or you want me to give you some more of the southwest corner, as it's called?
Yeah, I think if you could give us a little bit more, in the next one, Alec would jump right to the exam.
Sure, sounds great. So she has a history of chronic headaches for which she sees a neurologist, and has sort of been diagnosed with sort of mixed tension or migraine type. She has bipolar 2 disorder, and then generalized anxiety disorder, which she's been under the care of a psychiatrist for some time. And then plug for RLR CP solvers, but Rabih sort of gave us a nice teaser for the case next week of why would someone having such debilitating headaches wait 9 months to come? And so really this came down to sort of the primary care doctor helping to take care of her, but she just had really poor experiences interacting with physicians with her mental health diagnoses before that. She just really didn't feel comfortable sharing these symptoms with anyone else. So it took her quite some time to present, and so that's basically it. So that's her past medical histories. As far as the medications, she takes bupropion, cyclobenzaprine, fluoxetine, triptan, so sumatriptan, and then quetiapine. And then her family history was notable for Sjogren's syndrome and depression in her mother. And then socially, she was a student and was had one male sexual partner, but no new recent sexual partner. She'd been with that person for some time, and then no alcohol, tobacco, or illicit substance use, and then no medication allergies.
Okay, perfect. Thank you so much, Austin. This is a very well laid out case. So it's very interesting. We have a patient that has the past medical history of headaches. So we're in a setting of a change of the pattern of her headaches, as it seems. And for me, I think that's a red flag. If the patient usually has headaches and is telling you that something has changed, it could mean a lot of things. And the time curve is of 9 months. In neurology, we think about, chronic time courses. Usually it's not so likely that it's going to be like a vascular type of thunderclap headache. and we think more about, long, slow growing lesions like a tumor, but also about inflammatory causes. Now, this patient usually is the pattern of the headache is not too clear to me because it is on the right back side, and the popping sensation that is worsened with mental health symptoms makes me think that maybe there's a component of tension headache here, but also I have to keep in mind that she also has a lot of medications, and one that I think jumps from this is quetiapine. I'm not sure about the other ones, but the antipsychotics, quetiapine, of course, is not the most common to cause extrapyramidal symptoms. Usually the first generation are going to be the ones that cause this more commonly. But it could still cause something like a dystonia. And I'm wondering if this could present like these paroxysms very localized to the right part of the back of the head. At this point, I'm not really sure if my differential is any narrower, but I'm looking forward to the exam to see if there's any point pressure when you touch the neck, if there's any like irradiation to the neck, to the muscles of the back. This patient could also have fibromyalgia that can be part of the spectrum of functional neurological disorders, which are usually can present in conjunction with a lot of mental health struggles. And so I'm just wondering on the exam if it's going to be nothing, which could also happen if the exam is totally normal, if we're going to find something. And I'm not sure, Rabih, what you think, but if this patient came to the ED, or if you were seeing her as a primary care doctor, how far on the workup would you go? Because I'm not seeing a lot of red flags from the presentation.
Well, that's such an outstanding question. I completely agree with everything you're saying, including the connections that you're making with her medical history to other diagnoses. I think that you're right. You're picking up some red flags, namely the persistence of the headache and the fact that it's a new headache pattern. And I think that if you're being authentic to the exercise, you're like, it's been 9 months. A problem in the brain itself, be it the brain parenchyma, the brain vasculature, the ventricles, or the meninges, is unlikely to remain with such a static course over months. This is a persistent but stable disease rather than a persistent and progressive disease process. So in the context of the schema we had outlined, the big picture one, are we going to find something specific inside the brain, outside the brain, or something non-specific? I think this case is most characteristic of disorders around the brain, not the brain itself, or a primary headache syndrome. And so I think if I were taking care of this patient, I would certainly be reassured by the lack of progression, but concerned by the persistence. And so that would prompt me to look very closely on exam for findings on the skin. And the workup might have to include imaging simply to look for underlying bony malformations. So could she have a skull-based disease process would be the most emergent thing to think about. If you remember, a long time ago, Gabby presented a case of syphilitic skull-based osteo. And the clue for that might be in something that Austin did when he was describing the headache. He said it hurt right here. And I think when people use their fingers to describe a headache rather than their hands, it's their finger, not their hands, you really should be worried about something coating the brain that's causing the problem. However, that probability is rare. These diagnoses are rare. And it's equally likely that she has a primary headache syndrome that can be pointed to with a finger, like a tension headache, or more characteristically, something called a nummular headache syndrome, where you can actually have a headache in a specific patch. Again, it's a primary headache syndrome, so we don't really understand the pathophysiology, but I agree with you. I think the concern for the most scariest causes of headache has been tampered by the lack of progression, but skull-based stuff is probably the most scary thing to rule out. Does that answer your question?
Yeah, for sure. Thank you. So Austin, tell us what happened in the exam.
Sure. Yeah, just an amazing discussion. So I'll give you the sort of the vitals of the exam, and then for the sake of time, we'll just we'll do one more aliquot and then reveal the final diagnosis. But basically, I don't actually have all the numbers, unfortunately, but her vital signs were completely normal, within normal limits. Her physical exam, I'll say her non-neurologic exam was completely normal. And then as far as her neurologic exam, she had tenderness to palpation of sort of the occipital knob on the right side, so kind of right where Rabih was pointing. But there was no obvious mass, there was no obvious deformity, there was no sort of asymmetry between the sides. She had normal neck range of motion and position. And then the remainder of her exam was without any focal deficits. And then her sort of mental status and psychiatric exam were also normal. And then as far as her blood work, suffice it to say that all the basic labs were normal. And that's it for this aliquot.
Okay, well, as expected, I think there's not a lot of brain or under the skull findings, but what is interesting is the fact that it's a point tenderness in the occipital knob. And I think, you know, Rabih, the way you framed it, I think makes a lot of sense and changes for me a lot of the way I was thinking about this case, you know, that it could be an impingement of the nerve, maybe like an occipital neuralgia, or I don't remember exactly what it's called. Like there's this nerve that comes out of some hole in the skull, and it has like a name that starts with an R, and I don't remember what it's called, but that I think could present like this as well. So yeah, I think, as you said, and I honestly think this is a really good point of reflection, because a lot of neurologists, I feel like, will order imaging, but may not order the right one, just because usually we forget that there's like a bone, like you can order specific bone imaging rather than just brain. And I think they will feel safe, you know, okay, so the brain CT or brain MRI is fine, but they are not gonna order the bone, how do you say when you order, like the bone specific one, which I think if not framed like, okay, this is an extra skull issue, we wouldn't have thought about. So yeah, I think I will go for imaging after this.
Yeah, I completely agree with you. I think that you're right. We do, the morbidity of a brain problem is so daunting that we, as soon as we think that's less likely, we pivot probably in general too quickly to saying, oh, okay, this is not something that I think is worrisome for the patient, and they'll probably have to live with it for the rest of their life. So let's just give some medications like sumatriptan and focus on that. But what falls through the cracks literally between that is the secondary extrinsic specific headache syndromes. And some of them are acute and devastating, like you can get zoster of the cranium. I've seen that. You've seen glaucoma, but there are some ones, and I think, in all honesty, I'm not sure what she has, but I know exactly what I would do in real life is to make sure that she does not have a skull-based lytic lesion or a skull-based tumor. And after that, if that is not productive pathway, then I think that it really is whether you call it a non-specific headache syndrome, like a nummular headache, or that you go chasing after exactly what you just said, which is that does she have a compressive nerve syndrome, be it that the occipital nerve is compressed in the neck, or a nerve compression syndrome that I don't know. So that's my mental model, but my mental model of the space is actually much more deficient than it is for secondary brain syndromes. Gosh, like we have been trained to pick those up like no other. So I'm really excited to learn from this case, but in large part because I have enough confidence to know what to do, but not enough confidence to be able to do this 100 times correctly. Maybe like 50% of the time I do it correctly. So these are like really cool learning cases. But I think the big theme is stay rooted to that big picture. Headache, specific diagnosis first, then non-specific. But remember, there are two categories within the specific diagnosis: under the skull and above the skull. And I think we forget about that above the skull a lot. All right, Austin, tell us more, please.
Yeah, wow, no, amazing thoughts. If if someone's able to make me like a co-host, I can share my screen and just show a image, and then that will be the final aliquot to put your money down, if you will. Okay, let's see here. Here we go. Okay, can you see my screen? Yes, okay.
Well, you're an expert in this, right? Please, because I'm not. I have no idea. I just know there's a brain, and I know
Okay.
what pons is. That's about as much progress as I've made so far.
I'm not
Please.
really sure what I'm seeing, but I don't know. I'm not really feeling confident. I don't see a lot of like a escalation, but is there something like under the sulcus of the cerebral, like on the bone, not on the, but I'm really not sure.
Yeah.
What can you? Well, okay, that's a good thought. No, what can you teach us, Austin? Sorry, I'm really out of my comfort zone right now.
Yes, no, I think it was Hans in there, but if you look right in this area, does that help you sort of localize to where something might be going on, and then sort of a different pictorialization here? I don't know if you can see my mouse. I'm so sorry
Yeah.
if not. I'm like moving.
No,
it
totally,
around.
and I think Hans totally called it. I think I haven't seen enough MRIs to catch that, but yeah, that's a really good thought. The Chiari-Arnold malformation, and I think in this case, the Chiari-Arnold malformation is the kind of displacement of the cerebellar tonsils compressing the cervical spine. And I didn't know that it could cause these symptoms. Like, so this is, well, it's a young patient, so yeah, I can present, I guess, in these demographics, but also like it didn't cause any other type of neurological focal symptoms, which I think it's interesting. Wow, that's a very unexpected plot twist.
Yeah, well, yeah, I think I have actually seen a patient with this condition, and I'm kicking myself. I didn't even think of it honestly in this case, but I think the history is so classic of it. But I'll tell you my story real quick. It was a patient who had headaches every time she would laugh. Literally, it's called a laughing headache, and you should look that up. But that's all I will say. This is a great case of what you're seeing here is exactly why you would have a recurrent but static non-progressive condition. Really, really cool. I'll pass the mic to Austin because I know you've thought about the slide, and I imagine you have a lot of reflections and teaching to share. So please tell us what the diagnosis was and what you learned from the case. Is a really, really educational one for all of us.
Yeah, no, amazing thoughts. And I definitely didn't have a framework of thinking, extracranial or intracranially. And this case was really humbling to me because I got lucky. I mean, I got lucky. The patient came to me, and, I think one thing I've learned in treating a lot of headaches in primary care is that the history is everything. Like, everything is the history. And so there was once this very sort of cynical internal medicine doctor that said that the internal medicine doctors are typically better at understanding headaches than the neurologists, just because we take a thorough history, and that's something that we do often more regularly. And so certainly there's superb neurologists, and that doesn't always apply. But in my experience, like we are able to get great histories, and we're able to make diagnoses like this. So I had no idea what was wrong with her, but it was debilitating her so much. And the symptoms were so odd. I just said, hey, I think we need to image this. And now that I think back, it's like, probably these chronic headaches that she's been having for some time were actually all related to this Chiari malformation. And she just had this sort of interesting description of how she was describing it. But the physiology of what she's describing sort of makes perfect sense. Like, her meninges and her brainstem are literally just going up and down, up and down. And when we were able to tease things out, unfortunately she got a bit worse, and she ended up having a syrinx. And so she was going to get, a neurosurgical procedure to address this. But I think having the bias of her mental health history, which I sort of undersold a little bit. She was like really struggling a lot. And I think if first pass, if someone came to my clinic and said, "Hey, doctor, my brain is like herniating and I can feel it herniating," if I really checked myself in my bias, I'd say, wow, this makes no sense. And I would really, it would be challenging to take a step back and be like, hey, I'm not sure what to make of this. Like, it just seemed like an odd complaint. So it was humbling for me because number one, I listened to the patient, which is the right thing to do. And that doesn't always happen, where I think we're all guilty of that, myself included. And then number two, I got lucky because I didn't know what the diagnosis was. But I think we were able to make a meaningful intervention in this woman's life, and she was really struggling. And it was contributing in part to how bad her mental health was as well. So that's why I really like this case and definitely learned a lot from it.
Absolutely amazing, Austin. I think this is such a fascinating case, and there's so many lessons. And I love that you're emphasizing that as we try to hunt for the disease, and I think equally important is understanding the person who is afflicted by it. And I think here realizing what this person carried and how that influenced their presentation, but more importantly, how that influenced how people were responding to their presentation is so powerful. And I know you keep up with all the RLRs, and I don't know if you've listened to the most recent one where I share a terrible mistake that I made. And so I think that the fact that you overcame all our biases, all the potential biases in this case is incredible and admirable, and equally admirable as you mentioning that that's not always the case, so thank you. And Vale, you got your neuro, and honestly, I hope the next time we discuss you get no neuro, because you're basically a neurologist. I mean, how confidently you discussed this case and how thoughtful you were about all the pieces being put together, including the headache schema, stupid mnemonic, and making gradual progress. And ultimately, I think you'll add this to your armamentarium. I have no doubt. How did it feel to discuss?
Thank you, Austin, for this amazing case. It was great to discuss with you again. And I mean, of course, Austin helped us a lot with the way you laid out this case. Really interesting diagnosis. And I think what you mentioned about the patient describing this headache on a very particular way, it's a testament to the fact that there's this saying, and I shared this in the last SLS episode, that there's this saying in neurology that I learned from Dr. Marty Samuels, that it goes like, neurology is the only specialty in which you talk with the organ that is affected. Mm-hmm. And so I think this is a good example of that, because the patient was telling us exactly what was going on, the paroxysm of popping sensation of something displacing on the back of her head. But anyways, thank you so much, everyone, for joining. And thank you, Rabih, for making such a safe space for all of us to discuss and learn.
Vale, someday I'll tell you the story of the cardiologist who talks to hearts. It looks very awkward and weird. So I agree with you. I think neurologists are the only people who can elegantly talk to their organs, but I've seen some very, very interesting people who like to talk to their organs too. It's not productive at all, I guarantee you. All righty, Lee, take it away, please.
Yeah, great discussion. I think there was a lot of wisdom shared today in the discussion. So yeah, a short recap of the case would be that we talked about headache and head pain, and how it's important to listen to the patient. How does the patient even describe the pain? And not just with their words, but also with the way they're pointing to it. Is it with their fingers on a localized area, or is he just pointing with his entire head? So that can also be relevant information. And then to start off with headache, divided up into primary headache syndromes and secondary headache syndromes. And then Vale also taught us that it's important to listen to or watch out for red flags, such as systemic symptoms of fevers, a thunderclap headache, or risk factor history. Who is this patient? Is he immunocompromised? Or what is his headache history in general? And then are there any focal deficits or signs of intracranial hypertension, such as blurry vision that might come from his papilledema? And then headache another helpful way of thinking of it, is it in the head? Is it of the head, so around the head? Or is it a systemic issue that causes headache? And then the Vale also shared with us that the cause that this was more chronic makes her consider less vascular and more mass lesions or inflammatory causes of headache. And because it was chronic and persistent, we thought more about, is it a cause around the head, or maybe a primary headache syndrome. So what I loved also in the chat, there was a great discussion, and there were examples for skull osteolytic lesions that were mentioned, such as syphilis, hemangioma, Paget's disease, plasmacytoma, and vanishing bone disease. So shout out for Shema for that differential. And what was an interesting point about this case, we got to discuss specific headache causes and divide them up into extrinsic and intrinsic, and how it's also important to make sure you choose the right imaging modality so that you can potentially see both of them. So 2 examples of extrinsic secondary causes that were mentioned too was zoster or glaucoma, for example. And then finally, the diagnosis was something quite special. It was the Chiari-Arnold malformation, which is when parts of the brainstem is dislocated or displaced downwards, so caudally. I don't know how you say that in English, but I think you know what I mean. And looking back at this patient, she was a young person, so it makes sense that a congenital disease could be more likely, perhaps. And then, yeah, it would be interesting to read more about what different kinds of manifestations this could have. But in our case, this was a young female presenting with this persistent headache and this weird localized popping sensation. So thank you so much for joining, and Austin also for sharing this case and this learning together.
Hey, Leah, that was absolutely superb. Thank you for setting the standard for teaching points. It really is so cool how you're taking so much complexity and representing in such concise way visually and through your narration. That was awesome. And thank you to everybody, really. All of you are taking the time to join us today, and Gurbani and for scribing, Leah for the teaching points, Vale for like stepping into the lukewarm seat to discuss after a long time. And of course, a big hug to our beloved Austin for another fantastic case. All right, we'll see you all next time. Bye.